Assalamu alaikum. Hello everyone, and good afternoon. I would like to welcome all of you in this first Kuwait medical microbiology webinar prepared by our team from the Kuwaiti Board of Clinical Microbiology. This webinar will talk about various topics regarding the antibiotic use, whether how to use them in a better way to treat multi-drug resistant infection, or in way of stewardship, or how to use them as outpatient. I would like to thank our esteemed speakers from the different specialties here, and they are pioneers actually in their fields, and I would like to thank them for joining us and for having the opportunity to share their knowledge with us. Unfortunately, this webinar is a short one. It's a substitute for those who knows for a conference that was planned last year, a 3 days conference. But unfortunately, it was cancelled due to the COVID situation in Kuwait. So inshallah, hopefully in the next year's upcoming years, we'll try to see you again in live conferences face-to-face with more lectures and more topics. For now, I would like to introduce our first speaker, our pioneer in PKPD in Kuwait, Dr. Sarah Al-Ghanem. Dr. Sarah, she obtained her bachelor degree in pharmacy from Kuwait University. She has completed her MSc degree in clinical pharmacy at the University of Strathclyde. Also, she completed her PhD in PKPD modeling and simulation of antimicrobial therapy at the University of Strathclyde, UK. She received internship training on solid organ transplantation and infectious disease from the King Faisal Specialized Hospital and research in Riyadh, Kingdom, Saudi Arabia. Currently, she is the Assistant Professor of Pharmacy Practice at Faculty of Pharmacy, Kuwait University. She worked previously as part-time clinical pharmacist for the solid organ transplant at Hamid Al Isa Organ Transplant Center and infectious disease and nephrology at Mubarak Al Kabir Hospital, Kuwait. So for now, I would like to welcome our speaker. If she might start, please, Dr. Sarah.
Thank you, Dr. Nasser, for the introduction, and thank you for the invitation to present these talks. I will try now to share my screen. Okay, thank you all for attending today's webinar to talk about how pharmacokinetics and pharmacodynamics principles are helpful to optimize medication dosing in the management of MDR infections. So with a cup of tea, let's start our talk. So in the United States, the antimicrobial resistance accounted for more than 2 million infections and 35,000 deaths. In the 2019, the CDC produces their report, and they divided the MDR infections into urgent threats with 5 pathogens and serious threats with 11 pathogens, and other 2 groups, which are the concerning threats and watch list pathogens. In the urgent threats and serious threat, we can see gram-negative infections are of main concern, and mainly the carbapenem-resistant Acinetobacter and the carbapenem-resistant Enterobacteriaceae, in addition to ESBL and the MDR Pseudomonas aeruginosa, which are the main focus of today's talk. But what about the MDR epidemiology in the Middle East and the GCC countries? We can see in this beautiful diagram that in Kuwait, we have a 25% ESBL with less CRE and Pseudomonas resistant to carbapenem, but we have endemic of the carbapenem resistant Acinetobacter, which accounted for 44% of infection. So we have a lot of MDR infections. Now, what about the available options against MDR infections? We have old antibiotics like carbapenem, for example, Merobilium, and colistin, and we have more newer agents like ceftazidime, avibactam, and ceftazoline, tazobactam, in addition to tigecycline. So for ESBL pathogens, we have number of options, but the options is decreasing with the different MDR pathogens. For example, for CRE, which are non-carbapenemase producer, we still can use the merobilium, but with certain conditions. We have more of the newer agents, the ceftazidime, avibactam, still within the spectrum. Colistin and tigecycline are other options. However, when we have CRE, which are carbapenemase producer, we cannot anymore use our carbapenem, and we have other limited options like the ceftazidime, avibactam, colistin, and tigecycline. When we come with the MDR Pseudomonas infections, we have also carbapenem, but again, with certain conditions, we can use our carbapenem. We have the newer options still susceptible, and colistin. However, we know that the tigecycline is not a treatment option for Pseudomonas infection since it's not within its spectrum of activity. What about the MDR Acinetobacter, which is most of the common infections? We see it in our ICU patients. For carbapenems, again, we can use it, but with certain conditions. For the newer antibiotic options, unfortunately, they do not cover for Acinetobacter. However, we still have colistin and tigecycline as options for this infection. And from the list, we can see that for merobilium, colistin, and tigecycline, the BKBD dose optimization has been done to optimize its concentration to still be effective in the treatment of MDR infections. In this talk, we will cover the carbapenems and how dose optimization is working in MDR infections. So for Merobilium administration, we know that Merobilium can be administered as short infusion over intermittent in less than 1 hour, or prolonged infusion, which under this umbrella, we include the extended infusion, which can be given over 3 to 4 hours, or as continuous infusion, giving over 24 hours. So now we have a question to the audience. So please, if you can show up the question, and I will appreciate if you answer it. We want to know your opinion about the use of a prolonged infusion, whether you think it's more effective method of administration for beta-lactam antibiotics compared to the intermittent infusion. So I'm not sure if the question is appeared. Yes. So we can give you a few seconds to answer this question. Okay, I think now it's time to see the answers and see our audience opinion about using the prolonged infusion for MDR infections. Okay, so I can see that 61% of our audience, they agree to use the prolonged infusion. 18% they are neutral, they do not agree or disagree, and we have 22% they totally disagree to use such approach. Very good. So majority of the audience, they agree on that, and we will see how to convince the others or not. Okay. The second question, we can move on to the next question. Again, I need to know your opinion. So the second question is, there is uncertainty, do you think that there is uncertainty as whether continuous infusion of beta-lactam antibiotics results is better between, better patient-centered outcome than intermittent? So do you think there is uncertainty with their outcome? Again, I will give you a few seconds before we see the answer. Okay, I think now we can show the answer. Okay, so still we have, so even though that we have 61% agreed to use the prolonged infusions for beta-lactam, but still we have high uncertainty about the outcome of patients. Okay, so this is why we want to talk today about beta-lactams, the prolonged infusion, because your result is not very different from a survey that has been done in Australia and in New Zealand to see the physicians' opinion about prolonged infusion used in critical patients, where they found that there is uncertainty regarding use of the prolonged infusion, high uncertainty in both groups, whether they are physicians, but this uncertainty is reduced with reduced with pharmacists. Okay, so we have, I think, in terms of uncertainty, similar idea to what we see in our audience. So let's see the evidence behind the prolonged infusion. By now, by reaching now 2021, we think that we have a lot of new antimicrobial options to treat MDR infections for gram-negative pathogens. But why we are still talking about prolonged infusion? As we mentioned in the previous table, yes, we have different options to treat MDR, but still they are limited. For example, for Acinetobacter, we don't have a lot of options. Okay, and also in some of data that they are suggesting that we have emergence of resistance during therapy. For example, with ceftazidime avibactam, there is evidence showing that we have emergence of resistance during therapy. So it's important that we utilize the available options, whether they are the old or new, wisely. And we have a lot of evidence to support the strategy of prolonged infusion to optimize the PK/PD profile for beta-lactams. And it is recommended as a treatment option, whether as monotherapy or in combination by guidelines. But as we mentioned previously, there is still some controversial regarding its outcome in treating patients. So we have recently two important guidelines to guide us how to manage MDR gram-negative infections. One published by the IDSA and the other one published by a group within the Middle East and GCC, because it's very important that we look through our region and see the susceptibility patterns, which is different from North America, and the availability of options, because we have more options available in North America, more than the one I presented in the table, that are not still available in our region. So it's important that we consider this. So what is the place of merobilium in therapy of MDR infection? In this table, we summarize the recommendations from the IDSA and the GCC and Middle East report recommendations. We can see for ESBL, for the IDSA, they go with the standard dose, not the prolonged infusion, for cystitis and polynephritis and complicated urinary tract infection, and the outside of UTI infections. For the regional recommendations, in terms of ESBL, the infusion type was not mentioned in their recommendation. However, carbapenems are options for complicated UTI and outside of urinary tract infections, for example, bacteremia, nosocomial pneumonia, and in complicated surgical site infection, and the complicated intra-abdominal infections. For CRE, for IDSA recommendations, carbapenem are recommended only if we have resistant to ertapenem, but we have still susceptibility against merobilium, and the carbapenemase testing results are either not available or negative. In this case, a standard dose is given for cystitis, which makes sense because merobilium can concentrate highly in the bladder. For pyelonephritis and complicated UTI and outside of urinary tract infection, we go for prolonged carbapenem infusion. In terms of the regional guideline, merobilium is recommended only if the MICs against the treated pathogen is less than 16, and it is used in combination therapy and as a prolonged infusion in cases of complicated UTI and complicated skin and soft tissue infections, and bacteremia and nosocomial pneumonia infections. So mainly the prolonged infection is for CRE more than ESBL. What about the other pathogens? For MDR Pseudomonas, the IDSA do not recommend carbapenem because mainly they use, instead of MDR, they use the term difficult to treat Pseudomonas infection, which by their definition, they are resistant to merobilium. So they don't recommend any carbapenem for Pseudomonas infection. However, in terms of the regional guidelines, the merobilium is used in combination therapy. The infusion type was not mentioned for the complicated UTI and complicated skin and soft tissue infection, bacteremia and nosocomial infections. For MDR Acinetobacter, in the IDSA guideline, they didn't report any recommendations, although in the CDC report, it's one of the urgent pathogens. However, in the IDSA recommendations for gram-negative infections, they didn't mention anything. For our region, it is definitely important to provide guidance. So merobilium is used as alternative therapy Again, if MIC is less than 16 in monotherapy or prolonged infusion. In complicated UTI and complicated skin and soft tissue infection. But if we have bacteremia and nosocomial pneumonia, then we use it as combination therapy and prolonged infusion. So we can see that prolonged infusion of merobilium is still recommended by the recent guidelines in certain situations. So let's go through basic concepts about the beta-lactams. So they display the time-dependent pharmacodynamic killing, which means that the time for which the free unbound drug concentration remain above the minimum inhibitory concentration is best predicting the bacterial killing. And the beta-lactam concentration should be maintained at least 4 or 5 times the minimum inhibitory concentration for extended periods during this dosage interval. When we look through the animal model, we see that the pharmacodynamic target for maximum bactericidal activity is the percentage above time of minimum inhibitory concentration of 40% of the dosage interval. And this is in E. coli and Pseudomonas infections. What about in terms of real data with clinical outcome? In this study, they analyze the achievement of DKBD indicator for febrile neutropenic patients and associate that into clinical outcome and divided patients into those with who respond clinically and those who did not respond. And they found that patients who respond had more percentage time above the MIC compared to those who didn't respond. So for patients who respond, we need a percentage time above the MIC, which exceeded 75% to have clinical success. Instead of only here, the non-respondent, they had average of 59. And in vitro model, we had the 40%. So this gives us information that for some infections, we need to even target more than 40% of the dosage interval where the concentration is above the minimum inhibitory concentration. In meta-analysis for prolonged beta-lactam infusion, comparing the intermittent infusion, we find that in these meta-analysis, the ones that I included are the ones that uses only randomized controlled trial in their analysis, because we have some of the meta-analysis included also observational studies, and this might affect the conclusions and have added bias. So I decided to go with only the ones that use the randomized controlled trial. So if we can see, we have mixture of infusion that has been tested. We have some studies, they went to continuous infusions, whether others they go with extended infusion. For continuous infusion, randomized controlled trial and meta-analysis, we can see that we have significant improvement in clinical outcome associated with continuous infusion compared with intermittent infusion. And this was supported by 2 of the meta-analysis. Also, in terms of mortality, the continuous infusion had improved mortality in 1 and there was no difference in mortality rate with other meta-analysis. For the extended infusion, we have one only meta-analysis which look only through the extended infusion, and in this analysis there was no difference between the extended infusion and continuous infusion in terms of clinical cure, but in terms of mortality, it has beneficial effect on mortality and reduces mortality by 10%. One meta-analysis only looked through both extended infusion and continuous infusion, and it didn't show any difference between prolonged infusion and the intermittent infusion, but there was 30% reduction in mortality, which was significant compared to intermittent infusion. So from these, we can conclude that it seems that continuous infusion is having better outcome compared with extended infusion, especially that the target population here are the severe sepsis or critical ill patients who have usually infections with very high MICs. So in the DALI trial, they look through the different antibiotics they use in critical ill patients and which were administered as continuous infusion or extended infusion. And they look through the achievement of the PK/PD target. They found that patients who had 50% of the fraction of beta-lactam above 50% of the time of the fraction of beta-lactam above the MIC, they had a positive clinical outcome, but it was more and higher patients with positive clinical outcome with those who had 100% of the time of the free fraction of beta-lactams above the minimum inhibitory concentration. So it is important that we have enough exposure of the beta-lactams across the dosage interval to increase the probability of clinical outcome for the critical ill patients. And this is illustrated clearly in the figure in your left hand, where you can see that patients who have 50% for total, and I mean about total, in the study they examined around 8 beta-lactams. So for the total ones, 48.9% only achieved the target, the PK/PD target of 50% above, 50% of the time above the MIC, compared to 35% for those who were on Merobilium only. I mean, compared with compared to 68. I confused myself with the plot, I'm sorry. Compared with 68.8% with those who were on Merobilium. For 100% of the time above the MIC, it was only 35% of all antibiotics, which are the beta-lactams, compared with around 42% for those who are with Merobilium. So it's clearly that we need enough exposure to attain our target PK/PD. So one of the reasons is from the DALI that why we are having better outcome with the continuous compared with the extended infusion is the attainment of the VKBD target. The other thing is the severity of illness, where a patient who are more have severe conditions, they are at risk of 5% increase of their negative outcome. So it's important that we target those patients who are severely ill and make sure that we have enough exposure for these patients, and they definitely need higher exposure compared to other non-severely ill patients. Going back to one of the meta-analyses that's compared both extended infusion and continuous infusion, the positive outcome in their sensitivity subgroup analysis for mortality showed that the continuous infusion had better outcome compared with extended infusion, and especially if we give it with loading dose. So it is important. We have more evidence to go with continuous infusion and loading dose to have a significant reduction in mortality for our patients. So in this slide, we are showing the probability of target attainment for merobilium after administration over either intermittent infusion or 4-hour extended infusion or continuous infusion with different dosing regimen. Because as we see in the previous slides, we have studies that uses extended infusion, other uses continuous infusion. We have a very important element, which is the exposure, that we need to have high exposure to our patients. So can we attain this with intermittent infusion or extended or continuous infusion? There is another factor other than the infusion itself, which might be the amount that we are given. So this sub-analysis of the DALI trial show us that here in this first plot in your, it's for me, it's in my left hand. So the probability of target attainment, which is usually we wanted 90% and above, it's showing that for extended infusion with 1 gram every 8 hours, and for continuous infusion given either as 1.5 or 3 grams daily, we have a breakpoint of MIC of 8. However, when we increase the dose amount to around 6 grams per day, given either as extended infusion or continuous infusion, we increase the breakpoint for this dosage administration to 16. So very important factor is not only related to the mood, whether we are giving the infusion over extended infusion or continuous infusion, the amount that we are given is very important to ensure that we are achieving the target concentration. So for lower doses, we only attain 8 milligram per liter for MICs of 8 milligram per liter. However, for 6 gram, we can go higher. And this is where the guidelines are recommending the carbapenems, especially merobilium, when we have the MIC for the pathogen less than 16. So if you have it above 8, then it's better to go with higher doses. And what is important here in the simulations that they use loading dose. If we go through other studies that they didn't use loading dose, we might have different breakpoints. So in this study, they use a loading dose of 500 milligram, and then they start their infusion. So the key message is the amount that we are using. So we can go with high dose prolonged infusion. A very interesting study recently published, they look through the intrapulmonary concentration of continuous infusion. In this study, they only focus on continuous infusion merobilium. And why this is interesting for us, because most of the infections we see in ICU is related to pneumonia. So it's important to know whether our treatment, the carbapenems, is effective in this group of patients, especially that merobilium is hydrophilic and will poorly penetrating the lung. So even with increasing the dose, we might see low concentration. But how low, and is it going to be effective or not? So in this study, they examined critically ill patients with nosocomial infection, nosocomial pneumonia only, and they evaluate two dosage regimen for merobilium, the 3 gram and 6 gram by continuous infusion, and they assess the achievement of target in the plasma and epithelial lining fluid. So what they found in this study, that definitely with increasing the dose, we will have high MICs in the whether in the plasma or in the epithelial lining fluids. It's significant in both, and this is a proportion. So we are increasing dose, we are increasing the AUCs in both sides. But the ratios of this increase is the same, it's around 30%, and this is of not statistically different. So in this plot, it shows clearly that with increasing the dose, we have increase in the concentrations. The solid line is showing the plasma with higher dose, and the dot line in black is showing the plasma concentration with lower doses. In the epithelial cell, we have a similar trend of increase with increasing the dose. But what about the probability of target attainment? So in this study, they said, okay, we want to achieve 50% of the free fraction of merobilium is above, is within the time above the MIC with these different dosage regimen. So what they found that in the epithelial lining, the fluid, we reach 90% of probability target attainment only at MIC of 2. Okay, so it's different from previous study, which they measure only the plasma merobilium concentration. Here we have it at site of infection. So even with using the highest licensed dose of merobilium, which is the 6 gram per day, we are achieving only the MICs of 2 milligram per liter. And this is, I'm sorry, and this is only in patients with good renal function. So if we have pathogens with high MICs, more than 2 milligram per liter, and we are treating nosocomial pneumonia, it's better that we go with alternative therapy as per this evidence. And I think I put this for food of thought. I thought it's very important to present it to you today. Again,
I'm sorry, Dr. Sarah, to stop you. Just a reminder, you have around 5 minutes to go.
Very good, very good. I'm almost finishing the presentation. So in terms of prolonged infusion in a special population, a very common question I think all of you, if you are dealing with critical ill patients and you have them using the different continuous renal replacement therapy modalities, a very common question is whether we use the prolonged infusion for this group of patients or not. And new evidence show, previously we didn't have very solid evidence, but now with this publication that compared the probability of target attainment of achieving 100% of the free fraction of merobilium above the time with the different doses amount, but this is for the intermittent infusion. We can see that for the different filtration rate, we are achieving the susceptibility breakpoint of 2, and it's good only with the using the intermittent and the CVV-HDF for a breakpoint of 2 milligram per liter. When we use the continuous infusion, okay, we increases the probability of achieving the target attainment up to 8, with increasing for the different rates and having the doses as 2 gram and 3 gram low filtrate rate, and for the highest filtrate rate as 1.5 and 2 gram. So the main outcome here that for patients going CRRT with MDR infections, we can go with continuous infusion, especially if we have high MICs achieving 8. We can go with prolonged infusion. So by now we know that for the different medications, to decide on optimal clinical dose, it's depending on different factors, and these factors are the reason behind the variabilities we see in the different results. So we need to be mindful when we read these evidence and see the variability come from where. It could be from the pharmacokinetics of the medications, which cause variability between patients and within patients. It could be from the antimicrobial effect on bacteria, which is very important that we look through the susceptibility, and we know the local susceptibility pattern to decide on the agents we are going to use, and if we are going to go with which administration route. And also if we have any dose limiting side effect, and the immune status for our patient, as we now know, very severe infections, they need really more exposures to ensure achieving the target. So in summary, we can see some advantage from the prolonged infusion, especially the continuous infusion over intermittent infusion. In critically ill patients, we see that it can decrease hospital mortality, and it's mainly beneficial for the severely ill patient with sepsis, and it's having a better cure rate and achieving the BKBD target, especially for high MICs ranging from 4 to 16. However, for patients with nosocomial pneumonia, it's better to go with alternative therapy, especially if we have high MICs which are greater than 2. With that, I end my talk, and happy to take any questions or sharing the experience. And thank you very much.
Thank you, Dr. Sarah, for the great speech. I think we have time for fast questions, maybe 2 or 3 maximum. So the first question we had was that study regarding a certain pathogen. I think we answered that. How about merobilium stability in room temperature in case it was given by continuous infusion? The second question.
Okay, very good question. I didn't mention here the challenges behind using the carbabinins as continuous infusion. The main challenge is the stability, because we have a lot of stability studies showing that it's stable at room temperature, which is 25 degree and less, around 4 hours. However, there is a new study that shows that it can be stable up to 8 hours, so, but with certain conditions. What usually is done for the continuous infusion is to change the bag every 3 to 4 hours and make sure that it's running for the 24 hour. It's challenging, but it's doable, especially in the critical, in the ICUs.
Yes. Okay. Next question, maybe it's not that related, but is merobilium safe in pregnancy and lactation? It is in relation to Clostridium difficile diarrhea and measure to avoid it, from Dr. Philippos, Surah Clinic.
Thank you for the.
Yes.
Yeah. So, but I didn't get it, the question. They mean
let's
about
say it's safety of merobilium.
in general.
It's not about baking. Yes, I think it's in general. So it's a little bit out of the
Yes.
lecture.
Yeah. Okay.
If you want to answer, or we can ask another question as you like.
Yeah, you can move on to the next question. No problem.
Okay. So next question, there are two questions that are related. So I'll just sum it up. You already answered. It's about the infusion. It's difficult to use the continuous infusion, especially for merobilium, to its stability, especially in ICU. The second is, what's your input about using MDR combination of carbabinins as salvage therapy for MDR Klebsiella resistant to all MDRs in general? So combination of carbabinins. Do you have any thought about this? It's again, I think, not about the continuous infusion only, about the combination of carbabinins.
Yes. Well, I don't recall it now. It was something I read about it a few years ago. So I don't have the answer for now.
Sure, sure.
Can't come
okay. Okay, I think that's it. We cannot take more questions. Just a note, we are talking about use of merobilium, but we are not advising to use merobilium all the time. We are talking about the use of merobilium against MDRs when we need to, not for all, like only for ESBLs, CREs, and when we need to. We cannot answer all the question. If you would like, we can get you in contact with Dr. Sarah later on, or maybe at the end of the sessions. Thank you for Dr. Sarah for your great effort. I think now we can move to our next talk.